Mitral clip works very well, but it's really limited to high-risk patients at this time, and it probably isn't going to move into the lower and intermediate risk patients. And for, if mitral clip's not a great therapy, we're looking at mitral replacement, okay? And so we have mitral clip that works well. It's not perfect, but it's pretty good. And mitral replacement, which gets rid of the leakage, but it's a big procedure and a lot of patients aren't a candidate. So with the Mitral Butterfly, we're talking about a potential therapy that can probably move into a lower risk patient. It's still a repair, which we'd really like to do in these patients. We'd much rather repair their valve than replace them. But it also covers multiple different pathologies. So it can work for degenerative pathology anywhere on the posterior leaflet, whether it's lateral, middle, medial, but it also should work in functional patients. So it's really going to cover the majority of patients with mitral regurgitation and with a repair technology. The mitral space is a very difficult space. So despite some really amazing engineering with some technologies, the problem is, particularly with the LV outflow, that a lot of these valves are just going to obstruct that. And that's just intrinsic to this space, okay? So, and the other issue is with a lot of these valve replacements, we're kind of making the valve fit in the anatomy. The nice thing about this technology is, first of all, it conforms to the patient's anatomy. So it's gonna fit in. It's not gonna make the patient's anatomy conform to the device. Rather, the device will fit in the patient's anatomy. Now, the other advantage is that it's focused on the posterior leaflet, which will address the overwhelming majority of mitral pathology, but it doesn't have an issue with impinging on the outflow tract like anything where we're replacing the valve or something focused on the anterior leaflet may. So the nice thing here is it's going to cover patients with, focused pathology. It's going to cover patients who have a pathology across the entire coaptation of the mitral valve. And again, importantly, we want to repair people's valves. We would much rather do that than replace them. So it allows us to do all this with a repair technology. So I think we're going to get a really nice balance between the simplicity of a mitral clip, but maybe with more of the efficacy of a replacement, but with a more kind of favorable safety profile. Another potential advantage is, one, we believe this technology is still going to be retrievable in case we find that it is not as effective as we'd like, and then we can retrieve the device. And also, theoretically, the patient should still be a candidate for many of the potential mitral therapies down the line. Should the patient have a good initial result and it fail with time, theoretically, this patient should still be a candidate for a mitral replacement as well. That this is going to be a good therapy for people with mixed etiologies for their mitral regurgitation. Again, also, I think it's a repair that we're going to feel more comfortable doing in some perhaps younger patients. It's an area where I think that we're going to probably get a little more efficacy in theory than you do with the edge-to-edge approaches, but you're not committed to a replacement that we don't want to do in some of the younger patients. Seeing it today, one thing that I became reassured of, that I'll be honest, I was a little nervous about, is how stable is this device. So I saw today in the animals that while the device is a retrievable device, it actually anchors in very well to the mitral annulus. It takes considerable effort holding the device to actually try to remove it. The other nice thing is that everyone's valve is different, and the same with the animals, and that the device is designed in such a way that it really can conform to everyone's anatomy and take into account any subtle differences that may exist. Also, the motivation behind this. This device was designed by a cardiac surgeon who understands the mitral valve and understands the what's needed to fix it, but also realizes that we need to come up with less invasive ways to do it. We're not going to stick to a set of surgical tools. I mean, the patients want, rightfully so, for us to be able to do this without incisions, without heart surgery. And I think this is a way where we can get, in many patients, near surgical type results with a transcatheter procedure. I mean, today, one of the most exciting things was meeting the team, and it's really a diverse group of very talented members. I mean, from engineers that can focus on the tissue to the stress of the nitinol frame to how the clinical trials will be run. It's a very exciting team, and they're the right people to make this technology work.